Hello and welcome to this lesson, cholecystitis. So first, let's understand what is cholecystitis. In order to understand cholecystitis, we have to know the biliary system inside and outside of the liver. So this is a schematic picture of the biliary system. The bile is going to be produced inside the liver and it is going to drain itself into the right hepatic duct here and left hepatic duct here. Both of them are going to drain their content into the common hepatic duct, and after that the bile goes and travels to the gallbladder. This is the gallbladder, you can see it here, and when it is necessary after digestion, after eating the food, the bile is going to go and travel from common bile duct, and at the end it is reaching to the duodenum. So in case of cholecystitis, we have inflammation of gallbladder, and it can be caused by obstruction. For example, we can have gallstone as a result of as a cause of cholecystitis. Also, we can have acalculous cholecystitis, meaning that there is no stone and the cause of cholecystitis is something else. So the main complaint of the patient is going to be right upper quadrant pain. And note that if you are having a patient who is presented with right upper quadrant pain, you have to know differentials very well for right upper quadrant region. So this is a schematic picture of quadrant in the abdominal cavity. Here we have right upper quadrant, and this is where we have liver and gallbladder here, and most of the diseases that are causing right upper quadrant pain are due to the pathologies to the gallbladder or liver. Here we have left upper quadrant, we have the right lower quadrant, and here we have left lower quadrant. So in case of cholecystitis, we have pain in the right upper quadrant region, and sometimes the pain can be also presented in the epigastric region, but mostly the main complaint is right upper quadrant pain. Now, what are the three main So what are the types of cholecystitis? We have three main types of cholecystitis. We have acute calculous cholecystitis, meaning that a stone is causing cholecystitis. We have acalculous cholecystitis, meaning that there is no stone as a cause of cholecystitis. And also we can have chronic cholecystitis. So in the first case, in case of acute cholecystitis, more than 90% of the cases which are cholecystitis are due to a calculous cholecystitis, and this is when we have a gallstone obstructing the cystic duct and it leads to inflammation and infection of the gallbladder. In case of acalculous cholecystitis, we have other reasons. For example, the patient might have sepsis, trauma to the gallbladder, or even post-surgical patients, and these group of patients can have acalculous cholecystitis, and here a stone is not the cause of cholecystitis. Also, we can have chronic cholecystitis, and it can be due to the acute or subacute and repetitive acute and subacute episodes of inflammation into the gallbladder, and as the result here we can have fibrosis and thickening of the gallbladder. So what is the pathophysiology overlining the cholecystitis? First of all, we have obstruction. For example, if the obstruction is due to gallstone, this gallstone blocks the flow of the bile to the cystic duct, and as the result, bile cannot flow into the biliary system and starts to accumulate inside the gallbladder. This causes increased pressure within the gallbladder, and intraluminal pressure in the biliary system is going to go up, and this causes pressure to the wall of the gallbladder and causing reduction in the blood flow. So reduction in the blood flow in the gallbladder causes ischemia, and following that we have inflammation inside the gallbladder. So the next step, when we have inflammatory response, and this is a inflammatory response secondary to bile stasis, and it is characterized by neutrophilic infiltration of the mucosa, muscularis layer of the gallbladder, as well as serosal layer. Also, bacteria such as E. coli, Klebsiella, and Enterococcus can infect the bile, especially in complicated cases. In case of acalculous cholecystitis, inflammation is due to reduction of the gallbladder perfusion and bile stasis. So the next point that you have to know for cholecystitis is signs and symptoms of cholecystitis. So the first sign is right upper quadrant pain. This is usually present in more than 90% of the patients, and this is a steady and severe pain in the right upper quadrant region. The pain can also radiate to the right shoulder and back of the patient, and the pain can persist for hours, and it is usually worsened with the deep breaths. Another symptom that we have is fever and chill. Recall that this is an inflammatory process, so in the inflammation we have fever and chills in the patient, but the fever is usually a low grade fever, and it is most commonly associated with cholecystitis, with simple acute cholecystitis. And if the patient is having high grade fever, it means that we have a severe infection or even complication of the cholecystitis. So nausea and vomiting can be another symptoms. Usually they are accompanying the pain. Also we can have morphe sign. Morphe sign is when we have palpation of the right upper quadrant region in the patient, and due to the pain, exacerbation of the pain in the patient stops breathing, and this is highly suggestive of acute cholecystitis. Another symptom is that the patient might have right upper quadrant tenderness, and this is with guarding and tenderness over right upper quadrant area. So what are the diagnostic tools that we can use in case of cholecystitis? First of all, in complete blood count, you are going to see leukocytosis and neutrophilia. Remember that this is an inflammatory process. This is an acute inflammation, and in the acute inflammation, we are going to have involvement of the neutrophils. So as the result, the patient will have neutrophilia and leukocytosis. In the liver function test, you are going to see mild elevation in AST, ALT, alkaline phosphatase, and bilirubin. And all of these elevations are happening because of the fact that the bile duct is involved in this process. Also, we are going to have elevation in C-reactive protein. This is a general inflammatory marker. It means that elevation means that the patient is suffering from an acute inflammation. It does not have any special meaning in case of cholecystitis, but the first line imaging that we are going to use in case of cholecystitis is ultrasound. And in the ultrasound, what you are going to see is, first of all, the gallbladder wall thickening, and this thickening is usually more than 3 millimeters. Also, you are going to see pericholecystic fluid, and also if the cause of cholecystitis is a stone, you are going to see presence of gallstone inside the gallbladder. So here in this picture, you can see an ultrasound of the patient who is suffering from cholecystitis. As you can see, the walls are thickened. Also here you can see the gallstone on the opening of the cystic duct, and also you can see the pericholecystic fluid in the scan as well. So another imaging that we can use in case of cholecystitis is hepatobiliary immunodiacetic acid scan or HIDA scan, and this is usually used when ultrasound is not conclusive. So this gives us a visualization of the gallbladder. So in case of positive HIDA scan, you are not going to see gallbladder. It means that the contrast has not entered into the gallbladder, and it means that we have cystic duct obstruction. So on the HIDA scan, you are going to see non-visualization of the gallbladder and cystic duct obstruction. We can also use CT scan, and it is usually used when we have complications like perforation and abscess inside the gallbladder. So what kind of managements we can use in case of cholecystitis? First of all, NPO, Nil per os, keeping the patient hungry and fasting, and it is done in order to minimize the gallbladder stimulation. Remember that stimulation of the gallbladder with the enzyme of cholecystokinin causes contraction of the wall of gallbladder in order to empty the bile into the biliary system. But when we have cholecystitis, especially when we have cholecystitis due to a stone and obstruction, this contraction causes very extreme pain in the patient. So NPO is very important. Also, we can use IV fluid in order to keep the patient hydrated, and this prevents hypotension in case of cholecystitis. For the pain management, we can use NSAID. Usually we are going to do this with the NSAID, and ketorolac is the drug of choice. But if the pain is severe enough, we can also use opioids for pain management. Another point is that we have to use antibiotics, and this is usually empiric antibiotics. You have to cover gram-negative and anaerobic bacteria. One of the regimes that you can use is ceftriaxone with metronidazole. So the gold standard for treatment of cholecystitis is laparoscopic cholecystectomy, and this is a procedure that removes the gallbladder from the body, and it is usually done within first 3 days of hospitalization. But the patient have to be given antibiotics before and after the surgery in order to prevent complication of laparoscopic cholecystectomy. For example, one of the complications that can happen here is peritonitis, so antibiotics are given to the patient in order to prevent the complication. Another surgical option that we have here is open cholecystectomy, and it is usually reserved for the patients who have contraindication for laparoscopic cholecystectomy. If the patient is critically ill and cannot do surgery, we can use percutaneous cholecystectomy. This is when we have a catheter placed into the gallbladder and draining the gallbladder and emptying gallbladder, and it is usually done if we have critically ill or old patient who is having acalculous cholecystitis. So what are the complications of cholecystitis? First of all, we can have gangrenous cholecystitis. Remember that in case of cholecystitis, the gallbladder is not emptying itself. So as the result, we have increased in intraluminal pressure of the gallbladder, and this leads to ischemia. And ischemia, if it is severe and long enough, can lead to tissue necrosis and gallbladder necrosis. The symptoms are very severe pain, high-grade fever, and signs and symptoms of sepsis. Also, we can have perforation of the gallbladder. Again, recall that after perforation, we have opening of the gallbladder, and the bile is going to transfer from gallbladder to the peritoneal cavity. So as the result, we can have localized or generalized peritonitis, and also we can have formation of the abscess around or inside of the gallbladder. This is usually suspected in the patients who are having signs and symptoms of peritoneal irritation. Another complication is cholecystoenteric fistula, and this is an abnormal connection between gallbladder and intestine, and it is usually done due to chronic inflammation and chronic cholecystitis. And in this case, if we have a large enough stones in the gallbladder, these stones can actually be transferred from gallbladder to the intestine and obstruct the intestine and cause what we call gallstone ileus, and this is usually can cause very severe pain in the patients. So the fourth complication is emphysematous cholecystitis, and this is happening usually because of gas forming organisms. For example, Clostridium can do this, and in this case we have infection of gallbladder wall from Clostridium leading to formation and accumulation of the gas within the gallbladder, and this is usually happening in the diabetic patient and the patients who are having high risk for gangrene or perforation. Thank you for watching.